Hello, my name is Liam Rappold, and I'm working with Dr. Ivan Wong in the Division of Orthopedic Surgery at Dalhousie University in Halifax. Here we present an arthroscopic fixation technique for recurrent posterior instability with posterior bone loss called the arthroscopic anatomic glenoid reconstruction using a distal tibia allograft with screw fixation. Here are our disclosures. The patient is positioned in a lateral decubitus position with 30-degree posterior tilt to make the glenoid horizontal. The arm is balanced in 6-degree abduction using the pneumatic arm holder. Standard surgical landmarks are identified and utilized as a guide for standard portal placement. Importantly, the posterior portal is kept parallel with the glenoid face for line graft insertion. Using the HoloLens, a 3D model of the shoulder can be positioned to assist with portal planning. In addition, the HoloLens enhances the accuracy of portal placement by allowing for visualization of the 3D model. Diagnostic arthroscopy is carried out through the posterior portal to evaluate posterior and anterior labrum. In this patient, marked synovitis was noted as well as significant posterior glenoid defect. Viewing through the anterior superior portal, the labrum was elevated from the glenoid to expose the glenoid defect. A traction stitch is used to retract the labrum to allow for viewing of the posterior glenoid with good exposure and to fully reveal the posterior glenoid defect. The glenoid is assessed posterior to anterior from the posterior portal using a calibrated probe. The posterior glenoid defect can be visualized and assessed while viewing from the anterior superior portal. An osteotome is used to save the glenoid face, decorticate, and expose the bleeding subchondral surface that will enhance bone union. The posterior glenoid rim should be 90 degrees to the glenoid face. Synovectomy was completed on the posterior glenoid rim. The posterior portal is repositioned to guide the graft parallel onto the glenoid. Through the posterior portal, 2 half pipes are used for guidance to create enough space and protect surrounding soft tissue during graft insertion. The frozen distal tibia allograft is prepared on the table in the operating room. The distal tibia allograft is first outlined to be cut 1 by 2 by 1.5 centimeters. The distal tibia allograft is seen being harvested from the cadaver bone. 2 holes are cut for mounting of the double-barreled cannula. Using the 3D model with HoloLens allows for better orientation for graft placement. Viewing from the anterior superior portal, insert the graft through the posterior portal using the half pipes as guides to the dilated posterior portal. Positioning the graft flush against the native glenoid by using the double-barreled cannula to maneuver. Confirm that there is no step off from the native glenoid to the distal tibia allograft such that there is a flat articular surface reconstructed. To ensure there is no gap between the distal tibia allograft and the native glenoid, compress the graft using 5.6 mm partially threaded screws. Using your finger, insert into the joint to confirm that there is no step and there is a smooth articular surface reconstructed. Set the anchors on the native glenoid, not the distal tibia allograft. This allows the glenoid labrum to be repositioned anatomically to the posterior glenoid face, similar to a posterior Bankart repair over the top of the graft posteriorly. This reattachment of the capsulolabral complex keeps the graft extra articular. Here we see the final view of the reconstruction with the glenoid and the graft covered by the capsule. As seen here, the humeral head is balanced and centered on the glenoid face. Thank you.